Hello everyone, welcome to my video channel. As promised, today I am going to discuss regarding the part 2, traction in orthopedics, especially regarding a Gardner-Well Thong, GWT. In this video, I will discuss regarding what is GWT, Gardner-Well Thong, what are the components of Gardner-Well Thong, the usage and indication of Gardner-Well Thong, what are the contraindication of Gardner-Well Thong? What are the complications of Gardner-Well Thong? And how do you apply GWT and the weight calculation in a cervical fracture? And lastly, additional notes. As an introduction, the Gardner-Well Thong GWT is a device for temporary immobilization during the initial stage as an adjunct to surgery or as a definitive treatment of the cervical spine injury or disorder. What are the components of Gardner-Well Thong? It consists of a rigid bar that follows a coronal contour of the skull with a hole on each end that accommodates placement of a screw into the outer table of the skull. These two screws are tilted in the vector of the pull, minimizing screw pull-out during the traction. This change in the screw angle offered a Gardner-Well Thong an advantage over prior cervical traction device. What are the usage of Gardner-Well Thong? Among the indications of Gardner-Well Thong are 1. Cervical dislocation or subluxation, example in unilateral or bilateral facet dislocation. C1 to C2 rotatory subluxation. Cervical traction helps in the reduction, stabilization, and realignment of the cervical spine. Number 2. Fracture, example in subaxial cervical fracture with malalignment. By restoring the sagittal plane alignment. Another example is traumatic spondylolisthesis of axis, example also known as hangman's fracture. Depends on which type, based on the Levine and Edward classification. Number 3. Deformity. This skeletal traction is utilized during spinal deformity surgery, example in the scoliosis corrective surgery. Number 4. During intraoperatively, skull traction has 3 purposes. A. In deformity correction. B. In spinal stabilization. And C. Head elevation, thereby permitting a safer surgical correction of spinal deformities. Number 5. Dispace access, whereby the Gardner-Well Thong applied to allow controlled distraction while performing multi-level ACDF. Anterior cervical diffusion. Distraction through the shoulder is applied using a white tape to help with the fluoroscopic visualization. Okay, next, we are going to discuss regarding contraindication of Gardner-Well Thong in a patient who is not awake or alert. So, another contraindication of Gardner-Well Thong is patient under alcohol influence that difficult to follow order properly or in an intoxicated patient. Another contraindication is in the presence of a skull fracture. And lastly, contraindication are infection overlying the potential pin site. In a stable cervical fracture, especially the one without neurological deficit, when only collar or other forms of brace may be sufficient, Gardner-Well Thong is not indicated. Another contraindication is the age of the patient especially in the children. What are the complications of Gardner-Well Thong? 1. Pin loosening or loss of attachment of the pins or pull off. Weeks after initial traction, it is usually due to resorption of the bone underlying the pin due to pressure or infection. Number 2. Asymmetrical pin positioning. Number 3. Superficial infection. The rare complication of Gardner-Well Thong is number 4. Perforation of the skull. It is a low-risk complication due to inbuilt safety mechanism that limits the extent of the pin penetration as nil as the superior pin angulation and contouring mechanism that reduce pressure at the pin cranium junction. Number 5. Another rare complication of Gardner-Well Thong is formation of brain abscess. Usually it is caused by a superficial skin infection which tracks to the pin entry site. This may occur when the pins loosen and are retightened. Number 6, the rare complication is neurovascular complication. Example, transient abducens nerve, cranial nerve 6, palsy, and laceration of the superficial temporal artery has been recorded. What are the area of pin placement in Gardner-Well Thong? Okay, this is one of my exam question. Pin is placed 1 cm above the pinna in line with the external auditory meatus and below the equator of the skull in a neutral position. Pinna and Gofsa identified the location of the key vascular or muscular structure to avoid when inserting the pins into the skull. These studies showed that there is a safe zone of at least 2 cm times 2 cm centered on the neutral position. If the pin is placed too anteriorly, the temporalis muscle and superficial temporal artery and vein are at risk. An anterior pin will apply an extension movement to the cervical spine. If the pin is placed too posteriorly, it will apply flexion movement to the cervical spine. A posterior pin with a flexion movement may facilitate reduction of a facet dislocation. The application of traction is best done in operation theatre under imaging guidance. And the next question is about the pin tightness. On Gardner-Well Thong, pins are tightened until spring-loaded indicator protrudes 1 mm above the surface. This is equivalent of 129 newtons, around 31 lbs or pound of force. Over-tightening by 0.3 mm leads to a 448 newtons, around 100 pounds. The failure of temporal bone usually occurs at 216 pounds. Over-tightening of the pins can result in penetration of the inner table of the calvarium. This may cause a cerebral hemorrhage or abscess formation. How do you do reduction with a serial traction for facet dislocation? First, initial 22 pound or around 10 kg is added. Weight are increased by 10 pounds around 5 kg every 20 to 30 minutes. Serial examination and radiograph taken after each weight is added. Weight is applied until the facet is perched. It means that it is resting on top of each other and more likely to be reduced or if there is a change in neurologic function. A locked facet mechanically irreducible in the sagittal plane due to superior process of the inferior vertebra below imparting a bony block to reduction when axial distraction was pulled. the superior facet beyond the bony block of the inferior facet. But the facet is still dislocated. The facet is perched, means that it is resting on top of each other and more likely to be reduced. A perched facet again is more likely to reduce as it is not mechanically restricted in the sagittal plane. Axial distraction has been shown to be a key factor in achieving perched facet, after which manual loads, typically flexion plus rotation, can facilitate reduction. What are the complications during a serial traction? Number 1. Failure to reduce. A bilateral irreducible facet dislocation is unstable and should be treated with an urgent open reduction after an MRI is performed. Number 2. There is a change in neurologic examination. With any change in the neurologic examination during the serial traction, the weight should be removed and an MRI should be obtained. Among the questions during my viva is, what is the weight calculation in traction for cervical spine fracture, example in CT burst fracture? Well, there is an argument regarding the weight usage, but from my previous teaching in my university, the weight is added progressively to the device. The amount of weight added to the end of the device will depend on the vertebra being treated, which is usually about 2.5 kg. That means 5 pounds per vertebra level. Initial starting weight is around 5 kg, 10 pounds for the skull. The weight will need to be reduced once the required neck extension has been achieved. Example, in C5 fracture, traction needed is around 17.5 kg, whereby 5 kg plus 2.5 times 5 per level. I am quoting from the original articles of cervical traction regarding Crutchfield and Gardner Thong. For light traction and adjustable brace, for the level of first cervical vertebra, the minimum weight is in pound is 5. Maximum weight is 10 pound. For the C2 cervical vertebra, the minimum weight is 6 pound, while the maximum weight is around 10 to 12 pound. For the C3 or third cervical vertebra, the minimum weight is 8 pound. The maximum weight is 10 to 15 pound. For the fourth cervical vertebra, C4, the minimum weight is 10 pound. The maximum weight is 15 to 20 pound. For the fifth cervical vertebra, minimum weight is 12 pound, while the maximum weight is 20 to 25 pound. For the sixth cervical vertebra, C6, the minimum weight is 15 pound, while the maximum weight is 20 to 30 pound. For the C7 of the seventh cervical vertebra, minimum weight is 18 pound, while the maximum weight is 25 to 35 pound. Please remember that this weight are used for correction of deformity only. A minimum weight 5 to 7 pound is used to maintain the corrected position. We are nearing the finishing line. As an additional note, the primary aims of therapy in the treatment of patients with an acute spinal cord injury are A. To minimize secondary insult to the spinal cord, B. To realign the spine, C. To improve the neurological recovery, D. To maintain a spinal instability, and E. To obtain an early functional recovery. These aims are achieved by 1. Decompression of the spinal cord by restoring the normal sagittal diameter of the spinal canal. Number 2. Or by removing a compressive lesion surgically. This is important in patients who have sustained a an incomplete spinal cord injury and are found to have a progressive neurological deficit. By restoring the normal position, it helps in the pain relief. Oh yay! That's all for today. I hope you have learned something from this video. I will do a part 3 of traction in orthopedics regarding stomach pain. See you later. Bye.